of XYZ, age 2 years, 11 months, boy, firstborn to third-degree consanguineous parents from Doddaballapur, religion being Hindu and informant being mother who is reliable. He was at to our ward on 31st of last month and examined on 2nd of this month.
Okay.
Chief complaints of the boy being puffiness of eye and face for 1 month, swelling of lower limbs and upper limbs for 3 weeks, abdominal distension and external genitalia swelling for 2 weeks, reduced urine output for 1 week.
Okay.
Coming to the history of presenting illness, the 3-year-old male child, firstborn to third-degree consanguineous marriage, was brought with complaints of puffiness around the eye and face for 1 month, incident onset, gradually progressive, from initially involving the periorbital region to the whole of face, more during morning hours, and then decreases as the day progresses. Then the mother noticed swelling of bilateral lower limbs after 5 to 7 days, insidious in onset, gradually progressive from feet to the knee, then in the upper limbs from hands up to the elbow. Same as well was more during the morning hours and then decreases as the day progresses. After 4 to 5 days of this, mother noticed generalized abdominal distension, insidious onset, gradually progressive, which later went on to involve the external genitalia as well. There was no associated pain abdomen. Mother has noticed reduction in both frequency and the amount of urine passed since a week. Initially, for a week, initially used to pass 6 to 8 times per day. And presently, the kid is passing 3 to 4 times in reduced amounts as well.
Okay. Ashray, wait. Before you go on to negative history, go to the previous slide. Yeah. So far we know that this child has been having a progressive edema, correct? Which is more in the face and also involving the limbs, and also now it has progressed to abdomen as well as external genitalia. Now, just to begin with simple questions, why is this edema more in the morning hours and then it decreases as the day progresses? And why is it why did it begin from the face?
Yes, ma'am. Usually, edema of renal origin begins this way, ma'am. Initially, the edema begins as periorbital puffiness and involving the face. After that, the limbs gets involved, lower limb and upper limb. Then the abdomen, finally the external genitalia gets involved. So this.
Why that pattern? Can you explain why that pattern happens?
Ma'am, because
why
of
is
the
it most prominent in the face?
Tissue content in the periorbital region, first the edema fluid accumulates, then further in the same manner it accumulates on the over the face, and then as the fluid shift increases, the lower limb, upper limbs and abdomen as well get involved. Finally, the genitalia.
So in renal edema, what you should remember is it's first visible where there is soft tissue maximum, that is around the eye, and that's why it is more visible around the eye before elsewhere. And it's more in the morning hours, again, because most of the time the child is sleeping through the night, and because of the supine position, the edema tends to accumulate around the face, and when the child wakes up in the morning, it is very prominent as facial puffiness. Okay, fine. Go on. Next page. Next slide.
Yes, ma'am.
Okay, fine. So, yeah, go on to the negative history.
No history of breathlessness on exertion, chest pain, recurrent respiratory tract infection, decreased physical activity, altered appetite, failure to thrive, jaundice, vomiting blood or blood in stools present.
Okay, can you substantiate all your negative history? Why have you asked me to this?
To look out for the origin of edema, ma'am. So thinking of edema, we can have of renal origin, which we thought so till now. Other than this, we can have cardiac origin, but to rule out cardiac origin, I asked history of breathlessness on exertion, chest pain and all.
Recurrent
respiratory infection. Then even since it's child, protein energy malnutrition also is very prevalent in India. So then when about decreased physical activity, altered appetite.
Instead of altered appetite, I think you can very specifically say reduced appetite. No, you will have reduced appetite. So I think you can just replace that word. Fine. Then go on.
And then failure to thrive for any other chronic illness if the child had. And to rule out for due to liver origin, I asked because of jaundice, vomiting, blood or blood in stools, ma'am.
Okay, fine. Yeah, fine. Another thing I would like to add here, no, you have nicely described your HOPI and you have spoken about the reduction in urine output.
Yes,
at the same time, it's always nice to ask if the mother has noticed a very concentrated urine, not just reduced amounts of urine, but also, they will report it as a highly yellow color urine, high color urine. Okay? So yeah, that is another history that you can add to very specifically say that the urine has reduced in amount and also has become concentrated. Okay.
Okay, ma'am. Should we ask about frothing of urine, ma'am? Because it's
I was coming to that. Yes, definitely. Especially in older children, they would notice that there's a lot of frothing of urine when they pass. So that would be another history that would suggest proteinuria specifically. So frothing of urine is another negative history to definitely ask. Okay.
Then
move on to negative.
No history of cola-colored urine, headache, or blurring of vision. This was to rule out the etiology. Coming to the etiology of the renal origin to rule out nephritic.
Okay.
I asked these features. Then no history of recurrent infections, weight loss, bony pain, blood transfusion, skin lesion, rashes, joint pain, any drug intake. This I asked to rule out secondary causes of nephrotic syndrome. Recurrent infections we can have in like HIV could be a cause. Weight loss and bony pain, weight loss can be either because of TB or because of any Hodgkin's lymphoma, all those things. Malignancy causing weight loss.
Malignancies, all right.
Then blood transfusion, again, hepatitis B could have caused. So any recurrent blood transfusions. Then skin lesions, rashes, joint pain to rule out autoimmune etiology. And drug intake, so drugs like NSAIDs, penicillamine, all those things can cause nephrotic, secondary nephrotic. To rule out that, I asked this issue.
Fine. Okay, go on.
No history of crying during micturition, urgency or increased frequency of micturition. No history of pain.
One minute. Yes. Here, urgency is a symptom that you should ask after the age of 5 years. Now, a 2.5-year-old child is very unlikely to present you with urgency, no? So looking at the age of the child, you ask the symptom. Urgency and hesitancy, those are symptoms which are described only after the age of 5 years, not before that. Okay? Crying during micturition and increased frequency is okay, but urgency is not appropriate here. Okay?
Yes.
Yeah, fine. That you ask for UTI. Okay.
UTI. Now coming to the complications, first I ruled out UTI. Or UTI itself could have triggered this episode of nephrotic syndrome. So to find out the trigger, I asked this history. And then there is no history of pain abdomen, vomiting, reduced appetite, loose stools, cough, hurried breathing, chest indrawing present. No history of headache, altered sensorium or seizures. This I asked because as a complication of nephrotic syndrome, we can have infections, being spontaneous bacterial peritonitis. Then any respiratory tract infection or cortical vein thrombosis, all those things. We ruled out renal vein thrombosis because of there was no pain abdomen, there was no the sudden decrease in urine output.
Hematuria. Gross hematuria is another feature of renal vein thrombosis. Now you've forgotten one very, very important symptom. One very common and important one you've forgotten in your negative history. Fever? You don't want to ask for fever?
Yes, ma'am. I should have asked along with cough.
You should have asked for fever.
Yes,
correct. So you ask for everything. Focus of infection you have asked, but the most common symptom of any infection, which is fever, you have forgotten. Okay.
Yes,
so you add fever.
Should have included.
Okay, fine. So at the end of HOPI, what do you feel this is?
Ma'am, at the end of HOPI, the edema is most likely due to renal origin.
Correct.
And etiology mostly pointing towards nephrotic syndrome.
Why are you saying that? Why are you saying nephrotic syndrome?
There is no history of any headache, blurring of vision, or any cola-colored urine ruling out nephritic. So hypertension, hematuria, and all we ruled out.
Right.
Then the patient predominantly is presenting with edema, a component of nephrotic syndrome.
Okay.
And this nephrotic
what
syndrome.
You should say here is when you're asked such a question at the end of HOPI, why do you think the edema is nephrotic? You start with the age of the child. Okay.
Yes.
What is the age of this child? It's 3 years. Now, 3 years is very common to be nephrotic than nephritis. Nephritis will usually present in the age group of 5 to 15 years, correct? Slightly older children.
Yes.
Less than 5 years, especially around this, 2, 3 years, it's very much nephrotic. So that is your first point. Secondly, the edema is a very classic description of your nephrotic. In children with nephritis, you will not see such predominant edema, such anasarca you will not see. Okay, nephrotic will have very classic facial puffiness, ascites, and pedal edema. A child with nephritis will usually come with some mild edema, some mild puffiness, and some mild, pedal edema. Most often, edema will not at all be their complaint. They will come with gross hematuria and complications of hypertension. And edema will be an examination finding by you. Okay, so that would be the second point why you will say that it is most likely to be nephrotic. The third one, of course, will be the absence of hematuria, the absence of hypertension. Okay?
Yes,
fine. Okay, so that's how you substantiate that it is likely nephrotic. Okay, now next slide you go. Fine. Here, no, go back. So, so far we're thinking it could be a nephrotic edema, correct? So, what are the causes of, you asked for no history of pain abdomen, no? So, what are the causes of pain abdomen in a child with nephrotic?
One can be because of hypovolemia.
Correct. Hypovolemia, why will hypovolemia cause pain abdomen?
There will be this splanchnic supply and all will be reduced, ma'am. So blood supply will be reduced to the organ. So ischemic.
So it is mainly gut ischemia. Okay, gut ischemia that basically causes pain abdomen. Then?
Ma'am, then it can be because of the infection of the fluid that has been collected. So
correct.
Spontaneous bacterial peritonitis can be there. Okay. Then it can be because of gastritis, ma'am.
Okay, for somebody who is on treatment with steroids, definitely there can be gastritis.
Can think of, yes, ma'am.
Then any other cause? Any child with nephrotic syndrome on treatment with steroids comes with pain abdomen?
That time we can think of gastritis, one, ma'am.
Gastritis and one more steroid complication. Pancreatitis. Okay.
Pancreatitis.
So 4 causes of pain abdomen in nephrotic syndrome: hypovolemia, peritonitis, gastritis, pancreatitis. Okay.
Okay, ma'am. Okay.
Okay, fine. Then just go to the next slide. No, the previous slide. Sorry, previous slide. Yeah, here you told me no history of breathlessness on exertion. So imagine the same child has come and the mother says that the child has breathlessness at rest only. What will you think?
Ma'am, then the ascitic fluid which was there through the pleuroperitoneal communication, it has moved into pleura also, ma'am. So pleural effusion also we can think of that.
Pleural effusion is one thing. Anything else that you can think of? Breathlessness in a child with nephrotic syndrome? Okay, so causes for breathlessness in nephrotic syndrome, one is severe ascites. A massive ascites itself, that amount of fluid in the abdomen can put upward pressure on the diaphragm and cause breathlessness. Okay.
Yes.
The second thing will be, as you said, severe bilateral pleural effusion. Third will be a pneumonia. Now you told me, right? Infections are very common in nephrotic syndrome. So pneumonia itself can present as breathlessness. And one more very important cause where a child who has nephrotic syndrome presents with sudden onset breathlessness will be pulmonary thromboembolism. Okay.
Yes, possible.
So these are very important. 4 causes of breathlessness in a child with nephrotic syndrome and 4 causes of what was the other thing? What is
pain abdomen?
Yeah, pain abdomen. Fine. Okay, fine. Go on.
Can I go ahead?
Yeah. Go ahead.
Now, coming to the past history, child was apparently normal 6 months back when he had similar complaints of puffiness of eyes and face progressing to involve lower and upper limbs, followed by abdominal genitalia. He went to a local clinic, was admitted for 3 days, where he was giving IV medications, details of which were not known by the mother. Following that, oral medications were advised for about 4 months. But then the mother discontinued because the symptoms resolved, all the swelling resolved within 2 weeks.
Okay.
After that, the child was asymptomatic for 3 months and presented with the following complaints. There is no history of tuberculosis or measles.
Okay, fine. Wait here now. So what do you think that episode was?
Ma'am, the similar episode the child was suffering
from.
Was first episode of
nephrotic syndrome. Correct. So what do you think this IV medication could have been?
Ma'am, mostly it is prednisone on that given.
IV medication. What could have been the IV medication?
Medications. One is that, one more steroids they would have given, or else they could have given to dissolve edema, furosemide they could have given.
Correct. So the IV medication, see, we don't give steroid IV in nephrotic syndrome, no. So
Yes.
the IV medication was most likely a diuretic. How do you get that history? You ask the mother if after starting the IV medication, did the edema come down? Did the child start passing more urine? And did the child's weight come down? Okay, so that will tell you that the IV medication could have been a diuretic. Then what do you think the oral medication could have been?
This was steroids, ma'am. Once the edema came down, they started on
steroids. Correct.
Yes.
So this must have been steroids. How do you confirm that? You ask them whether the steroid was given as an early morning dose before food, and whether it was advised for a longer duration. Now, what do you have to say about that 4 months duration? You think that's right?
Yes, ma'am. It was given for advice for longer duration, ma'am.
No, but is 4 months right?
4 months, they usually give 6 months, 6 weeks daily dose and 6 weeks of alternate day dosing, ma'am.
Okay. So how was that medication given? The mother will know, no, whether she gave it daily, whether she gave it alternate day. How long did she give it daily? How long did she give it alternate day?
She did not give it alternate day, ma'am. She gave for 2 months daily. After that, she stopped. That is what
so she stopped as soon as the edema has come down. Okay.
Come down. Yes, ma'am.
Now, after starting steroids, how long does it take for the edema to come down in a child with nephrotic? Do you know?
Around 8 to 10 days, it comes down.
Around 8 to 10 days, the edema comes down. So there's a very high tendency of this abrupt stopping of steroids by the parents themselves when they're not adequately counseled about the disease. So, so far we know that it was a improperly treated first episode of nephrotic syndrome in the past history. Okay?
Yes, ma'am.
Okay. Now, do you have any idea whether nephrotic syndromes can go into spontaneous remission? Do you think they can go?
Spontaneous remission. Possible, ma'am. If the trigger was any infection, as the infection gets controlled, they go into remission, ma'am.
Correct. So remember that although we say that all nephrotic syndromes need to be treated, including the first episode, there is a minute chance that around 5% chance that children with nephrotic syndrome may go into spontaneous remission in 1 to 2 weeks, even without the starting of steroids. But such children are likely to relapse sooner. So that's why we say that we don't wait for the spontaneous remission. As soon as your diagnosis is made, you have to treat them adequately. Okay. Now, why have you asked for tuberculosis and measles?
One is that the tuberculosis, if we had, it can flare up, ma'am, because of the nephrotic syndrome.
If he has had and not been treated for it.
Yes, ma'am. So that could have been. And measles itself can be a cause of nephrotic syndrome, ma'am. So
which other infections can trigger nephrotic syndrome? Now that you've asked measles.
Trigger any upper respiratory tract infection, fever, all those things can trigger.
Correct. So actually what they say, no, measles is one infection that if it occurs will lead to long-term remission in a child with nephrotic. Okay. So as a cause, I don't think you should specifically ask for measles. Okay. You should not really ask for that because measles is one infection. If it occurs, it leads to long-term remission. Okay. In a child with nephrotic syndrome. Okay, so you don't ask for measles, tuberculosis is okay. Fine, go ahead.
Fine. I'll remove that measles.
Yeah, that's okay.
Then treatment history, the child was not on any regular medications.
Okay. Go back. See now this, go to treatment history.
Yes,
see now this child has been unwell since the last 1 month.
Yes, ma'am.
Okay, and this is something that has happened previously also. Similar complaints. So from 1 month, the parents have not sought any treatment?
Ma'am, the thing is, the parents thought that like the previous time as the edema spontaneously reduced.
Yeah, that is one thing.
Parents avoided thinking it will go. But since it continued to progress and it was during this lockdown period, they got delayed. They delayed.
That is one thing. That is one thing. Okay, so the current episode also, has the child received any sort of treatment outside is important to ask. And in children and parents with nephrotic syndrome are they might just start self-medicating the child also. They know that they've given steroid previously. the edema went away in 1 or 2 weeks. So they may give the steroid this time also by themselves.
True.
So that is something that you should ask here. Okay.
Yes, ma'am.
Fine.
Yes, ma'am.
Go
She
ahead.
did not do anything. She directly got it to our hospital.
Okay. Fine. Go ahead.
Coming to the antenatal history, the child is of firstborn out of third degree consanguineous marriage with the gap. Okay, ma'am. This was for the second child.
Okay.
Which was born. The mother is a registered case, and the history is as follows. First trimester, there was nothing significant, ma'am.
Okay, fine.
First, second, and third trimester.
But what in the first trimester? What specifically should you ask for? Fever and rash, especially
any infection that is led to congenital.
Correct. Any infections, any torch infections, especially things like congenital syphilis, toxoplasmosis, rubella, CMV. All this can be causes for secondary congenital nephrotic syndrome. Okay. So that history will be important for you to ask, including hepatitis B, HIV also you should ask. Okay.
Okay, ma'am.
Fine. Go ahead.
That was not present in our case, ma'am.
All right. We didn't have. Okay. This child didn't have. Okay.
Birth history also, it was full term normal vaginal delivery.
Go back. Second and third trimester was fine. No? Okay, fine. Okay.
Yes, ma'am. Fine.
Okay, fine. Go ahead.
Full term normal vaginal delivery, delivered at government hospital in Dotpalapur. When baby cried immediately after the birth. Birth weight was 2.9 kg. It was immediate breastfeeding was started, and breastfeeding was done adequately on demand at day and night, and there were no feeding problems noticed. No other complications as well was there in the neonatal period.
Yeah, see, I think I've told this last time. This is not postnatal. Postnatal is for the mother. For the baby, it's neonatal history always. Okay.
Okay. Yeah. I should mention it as neonatal over there. Okay.
Yeah, you should mention it as when you're discussing the birth history. You should say antenatal, natal, neonatal. Postnatal period is for the mother. Neonatal period is for the baby. Okay.
Yes, I'm sure. I'll make that change.
Okay. Yeah. Sure. Go ahead.
Developmental history. All developmental domains achieved till date.
Okay. Can you go back? Can you tell me 1 or 2 conditions where you have developmental delay in nephrotic syndrome?
One, steroid toxicity itself can lead to developmental delay. Growth retardation can be there.
Correct. But which domains?
Predominantly motor.
Correct. Gross motor. In that also gross motor.
So yes.
Long-term steroids in a child with nephrotic syndrome can give rise to predominant gross motor delay. Okay. Then
nephrotic syndrome can lead to CKD, ma'am. That will also can lead to growth.
Not all nephrotic syndromes will go to CKD. No, only steroid-resistant nephrotic syndrome will go to
CKD.
Okay.
That can also cause growth delay, ma'am. Then anemia can be a cause of delay, ma'am.
Why would a child with nephrotic syndrome have anemia? Nutritional.
Again, ma'am, nutritional, or it can go to CKD, and that will be a problem. So nutritional.
I want you to tell me more, more likely causes, syndromic causes of nephrotic syndrome that can have developmental delay, mental milestones.
Yes, ma'am, that is possible. Syndromic causes all Dennis-Dress syndrome.
Okay, then more important one?
Galloway syndrome.
Yes. So I want you to remember in this, if somebody asks you syndromic causes of nephrotic syndrome
also.
That can lead to developmental delay. 3 important things that you should say. One is Galloway-Moat. The other one is Pearson syndrome. Okay, Pearson you should remember. And you can have Frazier's also will have very mild mental delay, will not have a very significant one. Okay, so you can give Pearson and Galloway-Moat. That will be the most important ones to state. Subsequently, of course, you can talk about steroids and CKD and all of that. Okay, but when asked about developmental delay, try and mention the syndromes that are associated. Okay, fine. Go ahead.
Immunization history. The child is immunized up to date according to the national immunization schedule. BCG scar was present, and optional vaccinations like pneumococcal vaccine were not taken.
Which other optional vaccine are you worried about? Do you want to specifically ask?
Pneumococcal, ma'am. One.
Okay.
Then varicella.
Very good. Yeah.
Then HIV. HIV is now already coming.
Yeah, that's in your schedule. No, that's already in the schedule. Another one? Influenza vaccine is another thing that you should ask.
Yes.
Okay, fine. So 3 important vaccines that you should ask in immunization history will be pneumococcal, varicella, and influenza. Fine, go ahead.
Yes, ma'am. And coming to the dietary history, the child was exclusively breastfed till 6 months of age. Complementary feeds was started at 6 months of age with ragi sari. It was given 3 to 4 times a day. Gradually, they increased upon it, and breastfeeding was stopped by 1.5 years of age.
Okay, go to the next slide.
There was mixed diet the child was taking, but still there was around 35% calorie deficit and 30% protein deficit.
Okay, fine. Another thing that you should ask in a child with nephrotic syndrome and he presents with edema is whether he is consuming any high sodium containing foods, because in your advice you will tell them salt restriction, no? So you should tell them, you should find out in your history if they are consuming any high sodium foods. So can you name a few high sodium foods?
Many salted snacks.
Correct, salted snacks. Then
so
potato chips, all this papad, pickles, correct. Then
all those things.
More common ones, bread, cheese. These are also important things that you should ask for. Okay.
Yes, ma'am.
Fine. And we'll finish off here only. What dietary advice will you give a child with nephrotic syndrome?
Adequate diet, adequate protein should be there, ma'am. Protein should be there.
How much?
Around 3 to 5 grams per.
No. Okay, so I'll tell you. Your protein requirement should be 130 to 140% of your RDA. Okay. So the first thing is you should give at least 1.5 to 2 grams per kg of protein in a child who has chronic protein loss. That is, say for example, in your steroid resistant nephrotic syndrome, you will advise 2 to 2.5 grams per kg of protein. Okay. Adequate calories as per the RDA. Then when the child has severe edema, you should advise for salt restriction. Somebody, I think, was just asking me a question about this. But sodium restriction leads to hypovolemic hyponatremia nephrotic syndrome. No, see, we will discuss this hypovolemic hyponatremia. In children who have severe edema, salt restriction is advised. Okay. And saturated fat also has to be less. Make sure that correct fat has to be less, and the calories that you receive from fat overall should be less than 30%. Okay, so I'm going to quickly say the points again if anyone's missed out. Protein should be 130 to 140% of the RDA. That is at least 1.5 to 2 grams per kg in children with chronic protein loss like steroid resistant nephrotic syndrome, 2 to 2.5 grams per kg. Salt restriction in severe edema. And saturated fat, low saturated fat diet, and the calories that the child receives from saturated fat should be less than 30%. Okay, 30%. These are 4 important points in diet in nephrotic syndrome. Fine, go ahead.
Family history, extended type of family with 6 members.
Okay.
So along with grandparents, parents, and 2 kids.
Okay.
She has 1 more kid, which is the kid is 11-month old, healthy boy baby. There are no abortions or stillbirths, no history of TB contact, no history of similar complaints or early death due to any congenital disorders in the family.
Okay. Somebody asked me if any less spicy food is advised. Not really, but children who are on steroids may be prone to develop gastritis, and if they are, only then you can advise. Otherwise, not that it's going to interfere with our treatment. Fine, go ahead.
Okay. This was the pedigree chart.
Fine.
The 3-year-old boy is the one who is affected as of now.
Okay.
Now coming to the
socioeconomic, we'll quickly go to Kupuswamy, lower middle.
Yes,
okay.
Lower middle class. Coming to the summary. Yeah. This here is a 2-year, 11 months old male child, boy of birth order first, born to third degree consanguineous marriage. Full-term normal vaginal delivery, belonging to class 3 Kupuswamy scale, all developmental domains achieved and fully immunized with dietary deficit of 55% calories and 30% protein, was brought to OPD with complaints of puffiness around eyes and face for 4 weeks, progressing to involve bilateral lower and upper limbs since 3 weeks, abdominal and external genitalia for 2 weeks, along with reduced urine output since a week. With this, would like to consider the edema to be of renal origin, Most likely, the child is suffering from first relapse of idiopathic nephrotic syndrome because of considering the past history. Probably it's minimal change nephrotic syndrome without any complications.
Okay. So here, why did you call this idiopathic nephrotic syndrome?
And because no other secondary causes could be made.
So by history, we did not identify any obvious, secondary cause. Now, in one point I would like to highlight here is children with idiopathic nephrotic syndrome very often have associated allergies. Almost 30% children will have. Okay, allergy to pollen, allergy to cow milk, allergy to house dust. So that is one aspect that you can ask in your HOPI itself. Okay, so if that allergy component is there, correct. If you ask about history of allergy there, then you will be able to substantiate your diagnosis of idiopathic nature of the nephrotic syndrome. Okay, that is one thing. And what most probably minimal change nephrotic syndrome. Why are you saying that?
Because no other cause again could be made out, and in this age group 2 to 6 years, minimal change nephrotic syndrome is the most common.
Yeah, no other cause could be made out is not the answer. This is probably minimal change nephrotic syndrome because minimal change is the most common histological picture that you come across in nephrotic syndrome. That should be your answer. Okay.
Yes.
And without any complications. Okay. Pending examination, you're saying without any complications. By history, you may not have. By examination, you may find something, correct?
Yes, ma'am. Okay, ma'am.
Yeah, so I agree with idiopathic nephrotic syndrome. I agree with minimal change nephrotic syndrome. And I would like to, when I'm presenting, I would like to say with no obvious complications pending the examination. Okay?
Okay.
Okay. Somebody asked me a question. Common secondary causes. Yeah. Dr. Ashray will tell you.
Ma'am, I didn't get the question, ma'am.
Vishruth has asked what are the common secondary causes leading to nephrotic syndrome. Can you tell a few?
Yes, ma'am. One is, again, as we came by history only, ma'am, other infections like hepatitis B, HIV can be the cause.
Hepatitis and HIV, correct?
Yes, ma'am.
Malaria is another thing.
Schistosomiasis, all those things, ma'am.
Okay.
Then coming to drug, NSAIDs most commonly, then penicillamine, gold and all. Then
more importantly, you should remember to mention SLE. Okay, even before you talk about drugs, no? Yes, yeah, so you should talk of SLE and other important causes, HSP. Okay?
Yes,
Henoch-Schönlein purpura and SLE are two important causes of secondary nephrotic syndrome. So other infections, autoimmune conditions, malignancies like Hodgkin's, non-Hodgkin's, and drugs. Again, four things here also.
HSP comes as nephritic or nephrotic?
It can present as both. It has a spectrum. It can present as an obvious nephritis. It can present with nephrotic. It can present with nephritis, nephrotic. So it has varied presentation, but nephrotic is also known. Okay. So remember to classify all secondary causes as infections, autoimmune, malignancy, and drugs. 4.
Okay.
Fine. Go ahead.
Coming to the examination, general examination, the child was alert, playful, well-looking, lying on the mother's lap. The child was not cooperative to be examined in other positions, so it was examined in the supine position on the mother's lap. Generalized edema was present with facial and periorbital puffiness, abdominal distension, scrotal swelling, lower and upper limb swelling.
Yeah, so here when you're telling in general examination, instead of repeating the same thing again, you can just say anasarca was present. That's all. Finish it off in 2 words. Keep it short.
Here I can mention the word anasarca.
Yeah. Okay. Of course you can. It's your examination finding, no?
Yes.
It's not history, no? It's examination. So you can say anasarca noted.
Okay.
Fine.
Vitals, temperature 98.6 degree Fahrenheit. So afebrile, pulse rate 98 beats per minute, good volume, regular, no delay, and all peripheral pulses were felt. Respiratory rate
was... Is it tachycardia?
No, ma'am. No tachycardia, ma'am.
Correct.
Respiratory rate 32 cycles per minute. Capillary filling time
32 breaths per minute. And which is normal for you. That also you should tell. Okay.
Yes, ma'am. Capillary refilling time was less than 3 seconds, so normal. BP was 85 by 50 mmHg, so it was around 58, coming around 58 to 90th centile, so normal, ma'am, again.
Okay, so one more thing I would like to add here is if it was an older child, say 7-year-old, 8-year-old, presenting with nephrotic syndrome, with obvious edema, not just blood pressure, you should also note for postural hypotension over here. Okay, because it's an early sign of shock, no? So
yes,
older children, remember to mention postural hypotension.
Fine, ma'am.
Okay, go ahead.
Head to toe examination, head was normal in size and shape. Hair, hypopigmented, luster.
Wait. Tell me some causes for microcephaly and nephrotic syndrome.
Ma'am, again, Gallwey-Mauvet syndrome cousins with microcephaly, ma'am.
Correct.
Then again, see, secondary to infection, ma'am, rubella, cytomegalovirus,
correct.
all those.
So torch infections. So three causes here: torch infections, Pearson syndrome, Gallwey-Mauvet syndrome. 3. Okay.
Then hair, hypopigmented, lusterless, and thin it was. Face periorbital puffiness and facial puffiness was present. Oral cavity, no ulcers, fissures at the angle of mouth and lip, no cleft lip palate, gum bleeds. Dentition was normal, no dental caries were present. Tonsils and throat were normal. Eyes pallor was
in oral cavity, 1 minute. Here in oral cavity, especially when you're examining a child who with nephrotic syndrome on steroids, remember to also mention candidiasis, oral candidiasis. Okay, keep that in mind. Yes. Oral thrush is one thing that you may have to mention, especially if the child is on steroids. Okay. Next, eyes.
Pallor was present. There was no interest. White spots, ulcer, scar, corneal neovascularization, conjunctivitis or conjunctival hemorrhages.
Yes, 1 minute. Why have you specifically asked for this corneal neovascularization, conjunctival hemorrhages?
Because protein energy malnutrition, considering that I asked.
Okay, fine. You asked for PEM, but in a child with nephrotic syndrome in the eye, there are more important things. Can you tell me?
One is pallor.
Okay, pallor is fine. Then, other than that? Okay, so
cataract we can do.
Correct. Very good. Cataract, microchoria, and also Buff-Talbot.
Alport syndrome, yes.
No, Alport's is not a truly nephrotic syndrome. I mean, it doesn't come under nephrotic syndrome. It comes under something known as glomerular basement membrane disorders. Okay, it's a slightly different entity, but so many of your syndromic causes for nephrotic syndrome, as we've just discussed, all your Pearson, Gallwey-Mauvet, then nail patella. There's another condition called nail patella syndrome. All these can have eye changes. Okay, nail patella is very much known to be associated with glaucoma. So such children may have Buff-Talbot. Microchoria is a very classical feature of Pearson syndrome. Okay, so I understand asking for all the corneal neovascularization and all that, but when you're dealing with nephrotic, try and include all this also, so that you know that you're looking for some etiological factor in nephrotic. Okay, so 3 things that you should ask here will be microchoria, congenital, any cataract, and Buff-Talbot. Okay?
Yes.
All right. Okay.
No discharge was present from ears. Nose and nasal cavity was fine. Neck examination was fine. Chest examination.
Go back. 1 minute. Go back. Why have you asked for rashes around the neck in specific? Anything?
Ma'am, it can either be because of photosensitivity, as in any autoimmune disorder, or because of vitamin deficiency to rule out.
Okay, fine. You're very much concentrating on PEM, but rashes, especially if you're thinking of SLE or HSP, of course, in slightly older children, not in this child. Adolescents with SLE can present with nephrotic syndrome, and they will have rash where? SLE is very
over the nose, ma'am.
Correct. Malar rash. Okay. And HSP, where is the rash?
HSP over the buttock.
Correct. Over the lower limbs and especially over the buttock. Okay. So that is the importance of rashes. Fine.
Yes, ma'am.
Go ahead.
Chest also no abnormalities were present. Umbilicus was normal in position, but it was stretched. Abdomen was distended. Genital examination, scrotal and penile edema was present. Spine was normal. Extremity, bilateral pitting edema up to knees and elbow was present.
Okay.
Skin was shiny over the edematous region. Skeletal system, no deformity was present. There was no cyanosis, clubbing, or lymphadenopathy.
Okay, 1 minute here. Tell me nephrotic syndrome with abnormal genitals.
Ma'am, Dennis-Drash syndrome.
Very good. Dennis-Drash, and you should also put Fraser here. Okay. Dennis-Drash syndrome and Fraser syndrome both have nephrotic syndrome with ambiguous genitalia. Okay, so that is important. Then this vitamin D deficiency is correct. You've asked for it. Remember that children with steroid-resistant nephrotic syndrome are very much prone to develop vitamin D deficiency and rickets. That is one point I want to highlight. And the other thing is, again, children with SRNS are known to develop hypothyroidism. Okay, so especially if you're examining a child with SRNS, it's nice to say that there is no thyroid swelling. Okay, not first episodes and all, but SRNS, if you're doing, then you should ask for that. Okay.
Yes, ma'am.
Fine, go ahead.
Anthropometry weight, it was a wet weight which we calculated, and it came between -2 to -3 standard deviation. Then the kid was not standing, so we measured the length only. So the length for waist was again -2 to -3 standard deviation. Head circumference was at -1 standard deviation. Mid upper arm circumference was 12.5 centimeter, and weight for length was again coming to -1 to -2 standard deviation.
Okay, so one thing I want to tell you here is you should ask for what is the weight without edema also, or what is colloquially called dry weight. No? The mother may remember. The mother may remember. Okay, so you ask so that, why is that important? You want to know how much of weight the child has gained or how severe your edema is. Okay, remember that when the fluid retention becomes more than 3 to 5% of your body weight, that is when edema becomes visible.
Yes.
Okay, that's when edema becomes visible. So that is one point. You should always ask for dry weight so that you know what is the weight gain. And another point to highlight here is that, see, even with edema, the child's weight is so much less than what is expected. So definitely the child has some significant amount of malnutrition. No, that is something you should remember. Okay, fine. Go ahead.
Yes. Systemic examination, GIT examination, child was examined in supine position. Coming to the inspection, abdomen was distended uniformly and flanks were full. Corresponding quadrants were moving equally with respiration. Umbilicus was central in position, but it was stretched, mostly due to edema. No scars were present. Superficial dilated veins were present. No visible peristalsis or pulsations were present. Hernial orifices are normal. External genitalia, scrotal and penile edema was present.
Yeah, so here, 1 minute. Not just the presence of scrotal and penile edema, but remember, scrotal cellulitis is one very common complication that happens in nephrotic syndrome. Okay, so there is no redness, there are no ulcers. So that is something that you should mention when you're examining when you're examining the genitalia. Okay, so remember that scrotal cellulitis, and especially when they have so much edema in the scrotum, the skin is very much prone to develop ulcers, and that often becomes a source of infection for the child. Okay, so remember to mention that. Okay, fine, go ahead.
Palpation, no local rise of temperature and tenderness was present, but pitting edema was present over the abdominal wall.
So that is another very important sign, this pitting edema over the abdominal wall, which is called your abdominal wall edema. What happens, most of the time to auscultate, you will put your stethoscope on the abdomen, like you want to, like say, when you put your stethoscope on it, it will leave a mark. That is a very good evidence for your abdominal wall edema. And not just tenderness, as I've mentioned previously, rebound tenderness is what is important. Okay, when you press the abdomen and when you leave it, that is when the child complains of pain, and that is a telltale sign for
pancreatitis.
No, spontaneous bacterial peritonitis. Okay, fine, go ahead.
No organomegaly also was present, ma'am. So abdominal girth was 53 centimeter. Then percussion, shifting dullness was present. Auscultation, normal bowel sounds were heard.
Okay.
Other system examination were normal, ma'am. RS, normal vesicular breath sounds were heard, and bilaterally attentive is equal. CVS S1, S2 heard, no murmur. CNS, no focal neurological deficit was present.
Yeah, so when you're examining the respiratory system, be very careful. Carefully examine for air entry on both the sides. Pleural effusions are very common in children with nephrotic. Okay, be careful while examining that. Okay, go ahead.
Yes, ma'am.
Yeah, so your diagnosis is?
Diagnosis is first relapse of idiopathic nephrotic syndrome, most probably minimal chain nephrotic syndrome.
Okay.
Without any complications, along with nutritional anemia and protein energy malnutrition.
Okay, fine. Fine. Go ahead.
Yes, ma'am.
Okay. So now the subsequent slides are made by me and I have given it to Ashray. So we'll try and give you some investigations and some case scenarios, Ashray, so you can help us learn better. Okay. So for this child, I did a urine routine. Okay. And this was the report. Can you interpret this for me?
Urine routine, protein was 4+, ma'am. So there's proteinuria. Then WBCs was 6 to 8 and RBCs were present 0 to 15 along with epithelial cells. So RBCs, this might be indicative of infection, ma'am, or it can be, since RBCs are high, microscopic hematuria can also be present, ma'am. So it depends whether
you start with the top. You start with top. So 4+ urine albumin is, so that means significant. Nephrotic range proteinuria is there. Okay. Yes, on your urine dipstick, when you get a 3+ or 4+ urine albumin or urine protein, that implies that there is a nephrotic range proteinuria. Fine. Sugar is nil. We're not worried about that. WBC 6 to 8. Do you think that there is an infection?
Possible, ma'am. Leukocyte count.
The child didn't have fever. You don't go to that weight. That is next stage. No.
Actually had UTI, ma'am. Colony count was high, ma'am.
Okay. No. Don't give me culture reports. Tell me this report.
This
WBC
report
was 6 to 8.
Then we
infection, no infection.
No infection.
How? Why no infection?
Ma'am, that much WBCs we can expect it to be there, ma'am, normally.
Okay. See, the first thing is, if the child is symptomatic, if the child has fever, if the child is crying during micturition, if the child is having some suprapubic tenderness, if there is something to indicate that there could be a UTI, you will take the 6 to 8 into consideration. Okay, because WBCs of more than 5 per high par field is going to suggest to you that there could be an infection, which is UTI. Yes. But you need to confirm this by doing a culture. However, if the child does not have any symptoms of infection and the WBCs are 6 to 8, it means that it is not significant. Now, what happens in nephrotic syndrome? What is the pathology?
Ma'am, depends on me. Podocytopathy.
No, you tell me, you're talking about minimal change here. No, so tell me minimal change, what happens? It's a podocytopathy, correct?
Podocytopathy. Yes, ma'am.
Okay, so there is leak of protein through the glomeruli.
Glomerulus, yes,
ma'am. So just like the protein can leak, even your WBCs can leak. Okay, so every time you look at a report of 6 to 8 WBCs, don't jump into the conclusion that it is infection. See if the child has symptoms. In the presence of symptoms, if the WBC is 6 to 8, then you go ahead and do a culture and confirm your UTI. In the absence of any symptoms of UTI, if the child is otherwise well, there is no fever, the child is happy but has edema, then you don't think of an infection, then you know that this is just a leaky WBC. Okay?
Yes.
Fine. Okay. Next is RBC. Okay, so there is microscopic hematuria.
Yes, ma'am.
Does that fit into the definition of nephrotic syndrome?
Yes, ma'am. It is possible to have, ma'am, atypical presentation. It doesn't fit into the yes, ma'am. As atypical presentation, we can have.
See, it doesn't fit into the definition of nephrotic syndrome, but up to 20% microscopic hematuria has absolutely no significance. Okay? But if the child had macroscopic hematuria, if the child had gross hematuria, that would be very important for us. Then we cannot think of simple nephrotic syndrome. Okay?
Okay.
Have you understood this point? That some amount of microscopic hematuria, up to 20% of microscopic hematuria in a child with nephrotic syndrome does not imply anything. But even a single episode of macroscopic or gross hematuria in this child will deviate from the diagnosis of nephrotic syndrome. Okay?
Yes, ma'am. Understood.
Fine. Okay. So what next investigation you want, Ashray?
Now urine culture we can send for, ma'am.
Okay. If the child has symptoms, I'll send for urine culture and see what happens. Okay. Yes, now I want to quantify this protein of 4+. What would you want me to do?
And then quantitative test we can go for, or urine spot protein create ratio.
Correct.
We can.
Correct. So what I want to tell you here is that a urine albumin of 3+ and 4+ is sufficient for you to make a diagnosis of nephrotic syndrome. But by definition, how much should you have? If I do a 24-hour urine protein, how much should the excretion be to call it nephrotic range?
Greater than 40 milligrams per meter square per hour, ma'am. Or 1 gram, 1 gram
50.
per meter square per hour in 24 hours.
Okay. Or simpler to remember, 50 mg per kg per day. Okay. Remember both. 40 mg per meter square per hour or 50 milligrams per kg per day. Both will be nephrotic range proteinuria. But in a child who is this old, like 2.5 years old, it's very difficult to collect urine for 24 hours. No? In such situations, you will do a spot protein creat ratio.
Yes.
And when do you consider spot protein creat ratio as abnormal?
Greater than 2, ma'am.
Okay, greater than 2 is nephrotic range proteinuria, but greater than 0.2 itself will be abnormal.
Abnormal, okay? Yes, ma'am.
Less than a spot protein creat ratio of less than 0.2 is normal. 0.2 to 2 will be less than 0.2 is normal. 0.2 to 2 will be nephritic range, and more than 2 will be nephrotic range. Understood?
Yes, ma'am.
Okay, fine. Okay, what next investigation do you want?
Then we'll go ahead and do a CBC, ma'am, complete blood count.
Okay. No, then, I mean, before CBC, you want to do anything? You want to confirm this is nephrotic syndrome?
What nephrotic syndrome?
You want to
albumin
confirm?
Levels, ma'am.
Okay, you want to do serum albumin and?
Serum albumin and RFT, ma'am.
And no,
cholesterol levels, ma'am. Cholesterol levels.
You need a cholesterol level. Okay,
yes,
fine. Go ahead.
Yes, ma'am.
So serum albumin here
is 1.3. And
okay, and total
cholesterol
is
raised,
400. Okay, what is this now? Interpret it for me.
Ma'am, there is hypoalbuminemia and hypercholesterolemia. Okay. Greater than 250 is abnormal and less than 2.5.
Okay, correct. Now, many people are asking whether renal biopsy is indicated in this child.
No, ma'am. As of now,
so as of now, you don't want to do. No, we'll discuss the indications for renal biopsy in a while. But no, I mean, I wouldn't do renal biopsy for this child at all. So, have we confirmed the diagnosis of nephrotic syndrome in him? He has nephrotic range proteinuria. He has hypoalbuminemia and hypercholesterolemia. Fine. Next investigation. Fine. Along with edema. Fine. Next investigation. What you want?
Ma'am, now we'll ask for a complete blood count. We can ask for chest X-ray, Mantox, CB-NAT.
Fine. Go ahead. Show me the next slide. What I've made. Yeah.
Yes.
Yeah. So interpret this.
HB was 11. PCV is 40. Total count is raised, ma'am. PCV is 40. So there's no signs of dehydration. Is okay, ma'am. It's not there. Total count was raised along with neutrophil is raised, ma'am. So acute infection is present.
Maybe he has some ongoing infection. Okay, then.
Yes. Platelet counts are normal, ma'am.
Okay. Anybody else has a difference of opinion?
6 next thrombocytosis.
Okay, right. You're saying it, no? Thrombocytosis.
Thrombocytosis, yes.
Okay. And then don't you think that there is some amount of hemo concentration? For a hemoglobin of 11, how much should your PCV be?
33.
33 is what you expect. I have given you 40 here. 40. So is there hemo concentration?
Yes, ma'am. Hemo concentration is
so that is the first thing. So when you look at the CBC report of a child with nephrotic syndrome, first point to see is there hemo concentration? Because what happens? What is the pathogenesis in nephrotic syndrome? You have underfill, overfill. You have both, no? According to underfill theory, your intravascular volume will be less. Okay. So then there will be hemo concentration, no? Obviously. So that is the first thing to look for. Next, you said total counts are raised with some amount of neutrophilia. Okay, maybe the child has some ongoing infection. We'll figure it out. We also thought some 6 to 8 WBCs. Maybe some infection. And thrombocytosis?
Again, indicative of this thing only, ma'am. Hemo concentration only.
Correct. Hemo concentration. Correct. Hemo concentration is one cause for increased platelet count. Okay. The other thing is if the child was on steroids. Steroid is another thing that can cause increase in platelet count. Okay. And one more point is in the absence of an infection, a slightly raised total count with neutrophilia again will suggest that it could be steroid induced. Understood?
Yes, ma'am.
Correct. So steroids are known to increase your total counts, especially neutrophils. It causes neutrophilia and lymphopenia, no steroids.
Yes,
yeah. So in the absence of infection, This is how you can substantiate these findings. Okay?
Yes, ma'am.
Okay, fine. Go ahead.
Absence of infection. Yes, ma'am. Understood, ma'am.
Okay.
Then serum electrolytes, ma'am. Sodium was 130.
Somebody has a doubt on CBC? Anybody has a doubt on CBC? No, no. I hope you have understood.
No, ma'am. Increased platelet question mark there put, but you have explained it, ma'am. So,
yeah, that I explained. Increased platelet is 2 reasons. One is hemoconcentration or steroids. Okay. Fine.
yes, ma'am.
Okay. Electrolyte.
Next, serum electrolyte. Sodium was 130, potassium 3.6, and chlorine was 100, ma'am. So,
okay.
hyponatremia is present.
Hyponatremia. Okay. What sort of hyponatremia do you think this boy has?
It can be dilutional hyponatremia, ma'am.
Okay. So, how would you classify hyponatremia?
Pseudo hyponatremia, euvolemic hyponatremia, and
correct.
It can be pseudo hyponatremia, euvolemic hyponatremia, and 2 more was
hypovolemic hyponatremia and hypervolemic
hyponatremia. Yes.
Okay, so remember that this finding of this low sodium in children with nephrotic syndrome is very common, and this is called dilutional hyponatremia, as you correctly said. This is because of 2 reasons. One is retention of water, and the other thing is an increase in ADH. Correct?
Yes.
So this here is where your overfill response comes. Overfill pathogenesis says that there is more of sodium retention, but remember that the amount of water retained is always much more than the sodium. So there is some amount of dilutional hyponatremia that is there. Understood? Or you want me to explain this again? Understood, no?
Understood, ma'am. I'll just look at the charts. Yes, ma'am, they've understood.
Okay, fine. Okay.
Then renal functions. Blood urea was 134, serum creat was 0.7. Again, blood urea is increased again because of dehydration, chemo concentration, blood urea.
Okay. He has AKI or he doesn't have AKI?
No AKI, ma'am.
How do you know?
Serum creat is within normal limits, ma'am.
No. See, this is wrong. Okay, let me explain this to you. Remember that in pediatrics, AKI is present, correct? Somebody says AKI is present. So remember in pediatrics, we don't have like what is the cutoff in adults that you take? Upper limit?
1.2.
Correct. 1.2 we take.
1.2. Yes, ma'am.
1.2 we take. Now that is not the case in children. In children, what you should do is you should calculate an EGFR. That is estimated GFR. Okay, that is calculated with the formula 0.413 into height in centimeters divided by serum creatinine. Okay. And any GFR that is less than 90 height in centimeters divided by serum creatinine. Okay. So that will, anything that is less than 90 will surely tell you that the child has AKI. There are different stages of AKI. And as someone has correctly mentioned, that a 0.3 milligram rise over the last 48 hours. Now see, in this child, we don't know what the baseline creat is, but you should look for what is the age appropriate creat. A child around 2 to 3 years will have a creatinine of around 0.35, 0.4, that's all. Okay. So what is the appropriate creatinine for that particular age? From that value, is there a rise? If there is a rise, this child has AKI. So don't look at only creatinine to say whether the child has AKI or not. Please calculate EGFR. Understood?
Yes, ma'am.
Okay, and look at the urine output. Look at the rise in creatinine from the baseline value. Okay, look at the rise in creatinine from the baseline or age appropriate creatinine value. Okay, so there is AKI in this child. What type of AKI is there?
Renal AKI only, ma'am. It is.
No, this is not renal AKI. This is pre-renal, correct?
Pre-renal.
Why are you saying it's pre-renal?
Hypovolemia could have led to.
Okay, that is your probability. But on this investigation, looking at a urea of 134 and creat of 0.7, remember that in pre-renal AKI, your urea will be extremely high, like this. Okay, in hundreds and 200s.
Okay.
Okay. In your renal causes of AKI, you will not have. Okay, not based only on sodium levels. This is based on urea creatinine. 1 by creatinine ratio, you must have heard, no?
Yes, ma'am.
Yeah, so that is what you should calculate here to say if it is renal or pre-renal. Okay? In pre-renal, you have a very high urea compared to the rise in creatinine. Okay. If it was a renal, if it was entirely renal, I would have a urea of say around 50, 60, and I would have a creatinine of around 1.3, 1.4, somewhere there. Understood?
Yes, ma'am. Understood, ma'am.
Okay. Okay. Fine. But of course, this pre-renal AKI, as you said, is probably due to hypovolemia.
Hypovolemia.
Fine. Next slide. Okay, now I am giving a couple of case scenarios. This may not be related to this child, but this is only to discuss few complications and definitions correctly. Okay. Now,
yes,
say, for example, last time this child came to you with a pulse of 120, had a low volume pulse, had a respiratory rate of 34, had a blood pressure of 70/40, his CFC was prolonged. What is your impression and what will you do?
Now this child might be probably undergoing into shock, ma'am, because of hypovolemia.
Okay, might be going into shock. Okay.
Yes, ma'am.
What are the causes of hypovolemia in a child with nephrotic syndrome?
Because of the hypoalbuminemia, because of the fluid shift, the child might have hypovolemia.
Okay, so the child already is in a state of relative hypovolemia. All children with nephrotic syndrome are in a state of relative hypovolemia. But if such children will present with diarrhea, which is very common in spontaneous bacterial peritonitis, or if they are on diuretics, okay, if they are on high dose diuretics, and if the child has any features of infection that has pushed him to sepsis, all this can present as hypovolemia. Okay, and remember, children with hypovolemia will usually come with tachycardia, postural hypotension, low blood pressures, and very often, especially 2 years, 2.5-year-old children, the mothers will very classically say that there are cold peripheries. Okay, and of course, as we already discussed, hypovolemia is a cause of abdominal pain. Now, it is, remember that it's very difficult to assess shock in a child with nephrotic. Okay, they already have so much edema, you may not be able to palpate their pulses well. They already have so much edema, your CST may also be difficult to pick up. Okay, and as such, because of their nephrotic status, they will have low urine output. So, this tachycardia, fallen blood pressure, and postural hypotension, which is an early sign of shock. These are the 3 things which are very important. Okay. Now, how will what will you do if this child comes to A&E? How will you treat his shock?
Treat his shock. Fluids.
Correct. How much will you give?
At that time, not aware.
Okay. Fluids. So remember, if a child with nephrotic syndrome comes to you with shock, okay, you first give him 20 ml per kg of normal saline.
Okay, 20 ml per kg of normal saline.
Yeah. Now, in a child who doesn't have nephrotic syndrome, you can give another 20 ml. But in nephrotic syndrome, what do? You don't want to overload them with a lot of fluid, because all this fluid is going to leak out into the third phase. Instead, after the first bolus of 20 ml per kg, you will give them albumin. Okay? Albumin. Okay, you will give them 5% albumin at the dose of 1 gram per kg. Okay, so that is how you
give repeated infusions, or
no, you give them one infusion. Usually they will get better. 1 gram of kg of 5% albumin you give them, then they will get then they will improve. That what happens now, you're giving a colloid, no, so it will draw all the fluid into the intravascular
yes, ma'am. We might overload, no, ma'am. Then all the we have already given fluids and
no. See what happens, you will overload if the child has an AKI. If the kidneys are working well, then you will not overload them because they will excrete it out as urine.
Yes, correct.
Okay, so a child with nephrotic syndrome, if he has AKI, then he will go into overload. But a child with nephrotic syndrome without AKI, presents in shock, very safely you can give them 20 ml per kg of IV fluid first. If there's no response, give them 5% albumin at 1 gram per kg. Okay?
Okay.
Fine. Okay. So that is how you manage, that is how hypovolemia presents, and that is how you manage. Fine.
Okay.
So this is one of the complications of nephrotic syndrome. What other complications do you know?
Of nephrotic syndrome, infections.
Yeah. Okay. Infections, common infections, you tell me.
Peritonitis, cellulitis can be there. Then bone and joint infections can be there. Sepsis can be there. TB can be there. TB, ma'am.
Peritonitis, pneumonia, cellulitis. These are the three very important ones. Okay, peritonitis, pneumonia, and cellulitis. Common organisms that can cause infection?
Streptococcus pneumonia, ma'am.
Correct. Streptococcus, pneumococcus, staphylococcus,
then
influenza. Correct. Gram-negative sepsis, again very common. What are the causes for infection in a child with nephrotic syndrome?
Immunocompromised state, ma'am. The child will be in. That's why.
Okay. So the cause of that, one is the child is already immunocompromised because you might be treating them with corticosteroids and other immunosuppressant drugs.
Then there will be loss of.
Correct. Very good. Loss of immunoglobulins in the urine. IgG is lost in the urine. Also, loss of complement factors. Correct. Factor B in the urine. Okay. So these will be the important causes of infection because of corticosteroids and other immunosuppressants and loss of immunoglobulins and complement proteins in the urine. Okay. Another complication?
Then we can have thromboembolism, ma'am.
Correct. Where all can you have thromboembolism?
Renal vein thrombosis can be there. Then cortical vein thrombosis can be there. Then peripherally DVT can occur. Then pulmonary thrombosis. Pulmonary thrombosis can take place.
What are the causes?
Again, hemoconcentration can be there. Increased viscosity. Then loss of antithrombin 3 and protein S. Then increased fibrinogen count in the increased fibrinogen in the all these things.
Very good. Another thing is, most of these children with nephrotic syndrome have so much edema that they don't walk around. They're mostly immobilized. Okay, yes. So that can again cause thrombosis. And another major cause is when so much edema is there, all your peripheral veins are usually not accessible for IV lines. So they may be on a central venous catheter. Okay, so that again may predispose them to develop thrombosis. Okay.
Thrombosis. Yes.
The other complications that you should talk about is growth retardation.
Growth retardation, anemia. Okay. Yes, ma'am.
Yeah, and in SRNS, it can go to ESRD. So important complications that you should talk about will be hypovolemia, infections, thrombosis, growth retardation, in steroid-resistant nephrotic syndrome, progression to ESRD, and of course, depending on the predisposing factors, children with nephrotic syndrome can develop AKI also. Okay?
Yes, ma'am.
Fine. Next.
Case scenario 2. A 2-month-old girl presents with swelling of entire body since 1 week. On examination has generalized edema. Investigation shows urine albumin 4+, serum albumin 0.8, total cholesterol 250. Diagnosis.
Tell me.
This is a case of nephrotic syndrome. All 4 features are present. Edema, clinically, then proteinuria.
Correct. You want to qualify the nephrotic syndrome?
Congenital nephrotic syndrome.
Correct. Very good. Okay. So this is called congenital nephrotic syndrome. When the onset of nephrotic syndrome is less than 3 months of life, it's called congenital. What is infantile?
Less than 1 month.
Yeah, less than 1 year.
1 year.
Yeah, from 4, so less than 3 months is congenital. From 4 to 12 months will be infantile. And remember that congenital and infantile nephrotic syndromes are mostly, they have very strong genetic predispositions. All this NPHS1 mutation, NPHS2 mutation, okay, Finnish, Podocin mutations are very common. Yes. And there are some syndromes, as we've already discussed, that are associated with infantile nephrotic syndrome, like Dennis-Drash, Pearson, Frazier, Neil Patella, and Galloway-Mowat. Okay. So especially when you have a child with infantile nephrotic syndrome, be very careful with your head-to-toe examination. Genitals, microcephaly, eye examination, presence of your bilateral patella, all this becomes, and any dystrophic nails, okay? All this becomes very important when you are presenting a case of infantile nephrotic syndrome. Okay? So this is important to remember. And remember, most of your congenital and infantile nephrotic syndromes will become steroid resistant. And it's very important to diagnose them because they will very rapidly progress to ESRD almost within 1 to 2 years of their life. With an onset at 2 months, by 1 or 2 years, they'll be dialysis dependent. Okay. So very important to diagnose these conditions. Fine. And remember that all your torch infections can lead to congenital nephrotic.
Congenital nephrotic. Yes.
Fine. Next case scenario.
Next case scenario.
I'll read, Ashray.
Yes.
Okay. So this case scenario, a 7-year-old child with nephrotic syndrome. He was diagnosed at the age of 4 years. Initially, he had 1 episode per year. But last year, he has had relapses in January, June, October, and February. October 2019, that was supposed to be, sorry. That is October 2019, okay?
Yes, ma'am.
So what is your diagnosis?
Now we can call it as frequently relapsing nephrotic syndrome. Because
okay, based on what?
Greater than 4 episodes per year he has had, ma'am.
Okay.
Within a span of 6 months, if it is greater than or equal to 2 relapses within 6 months or greater than or equal to 4 relapses in 12 months, we can.
Yeah. So remember, somebody is asking me a couple of questions. 1 minute. Let's look at it. No, this is not at all steroid resistant. Okay, that is exactly what I'm trying to highlight here. So remember, see this child, he had onset at 4 years. Okay, so he had 1 episode per year. That means he's having an infrequently relapsing course. But in the last 1 year, he has had 4 relapses: January, June, October, and February. So 4 relapses in any 1 year duration, or more than 2 relapses in 6 months of initial response. In the initial 6 months. Okay, so he's had a diagnosis, and from that date, that day he was started on steroids. He responded from that day to 6 months if he has more than 2 episodes, or in any 1 year duration if he has more than 4 episodes. Then you can call it frequently relapsing nephrotic syndrome. Okay, fine. Yes. So how would you treat this boy now?
Frequently relapsing nephrotic syndrome, we can try initially small doses of prednisolone, ma'am, around 0.5.
No dose steroid. So after you treat this relapse with a 2+4 regimen, that is 2 mg per kg daily for 2 weeks, followed by 1.5 mg per kg alternate day for another 4 weeks. You will
9 to 12 months
go on to
alternate day.
Correct. Okay. 9 to 12 months alternate day low dose steroid. Okay, around 0.5 to 0.75 milligram per kg you can give them. That is one option. Low dose steroid. What is the other option?
Still, if it's not controlled, then we can try levamisole, ma'am.
Correct. So levamisole. What is levamisole?
Immunomodulator, ma'am.
And? But where was it first used?
Where was it first used? Don't know, ma'am.
Levamisole is an anti-parasitic agent. Okay, it was used for parasitic infestations, incidentally found to be an immunomodulator and useful in nephrotic syndrome. Okay. So the in a child with frequently relapsing nephrotic syndrome, either low dose steroids or levamisole. Okay, fine. Okay. Go ahead, next case scenario. So I hope you've understood the definition of frequently relapsing nephrotic syndrome.
Yes. Then case scenario.
Next case scenario. Okay, so a 6-year-old child with nephrotic syndrome. Initially, she had a infrequently relapsing nephrotic syndrome course. Now, her last episode was on the 7th of September. Okay, she was started on 2 mg per kg of Vicelone. What is Vicelone?
Okay, steroid, ma'am.
Correct. It is prednisolone.
Prednisolone.
Okay, and we had told them to do home monitoring of urine albumin. Okay. Now, on the 16th, 17th, and 18th of September, that is after 1 week of treatment, her urine albumin has been nil.
Okay, ma'am.
You see the child on 19th. What will you do? You see the child, there is no edema.
Alternate day regimen will shift.
Correct, correct. So what I want to highlight here is, in the treatment of a relapse, you continue 2 mg per kg daily steroids until the child goes into remission. That is defined as 3 early morning specimens of urine albumin being nil. Yes. Okay, so as soon as that happens, you will change over to alternate day. How much dose will you give?
1.5 milligrams.
1.5 mg per kg alternate day. Fine. So you have given that. Okay, go to the next page. Next slide. Okay. So what happened? You gave that from the 19th. 1 week she has taken alternate day therapy. She has now come to you on the 28th of September. Now she has redeveloped her edema and her urine albumin is 4+.
Yes.
What has happened to her?
We can call it to be steroid dependent nephrotic syndrome.
Wrong. So remember this. This is a very important point. Yeah, you should have 2 consecutive such episodes to call it steroid dependent nephrotic. Okay. So steroid-dependent nephrotic syndrome means a child who has been previously responsive to steroids has 2 consecutive relapses within 14 days of stopping steroids or when on alternate day therapy with steroids. Okay. Yes. So remember, in steroid-dependent nephrotic syndrome, that 2 consecutive relapses is very important.
2 consecutive relapses. Yes.
Okay. So this is not steroid-dependent nephrotic syndrome. That is what I wanted to highlight to you. Yes. This child should have 2 such episodes. Only then you will call it SDNS. Yes. Fine. Next slide.
I mean, this case, then what do we do, ma'am?
Okay. So what do you do now? She has relapsed when on alternate day regimen. Now again you go back to 2 mg per kg daily steroid until she goes into remission. Once she is in remission, then you make it alternate day. Now again, when on alternate day, if she has a relapse, then your diagnosis becomes steroid dependent nephrotic syndrome. Okay. And what will you give for steroid dependent nephrotic syndrome?
Same, we can try small dose for a longer period or else levamisole.
No. See, what happens in steroid dependent nephrotic syndrome is they are dependent on some particular dose of steroid. If you give them low dose steroid, they will relapse. Yes. Okay. And that dose of steroid you cannot continue for a long time because of steroid related side effects. So any child with steroid dependent nephrotic syndrome is a candidate for alternate immunosuppression. What are the alternate immunosuppression that you can use? You can use oral cyclophosphamide. Levamisole is correct. Like levamisole is a drug for FRNS. For steroid dependent nephrotic syndrome, oral cyclophosphamide and MMS.
Okay.
What is the most important side effect of oral cyclophosphamide?
Leukopenia.
Correct. Leukopenia. Okay. Yes. Leukopenia is important. MMS is a very safe drug with very mild side effects, some GI side effects, some abdominal pain, diarrhea, not much. Very safe drug. Okay. So those are the 2 drugs for steroid dependent nephrotic syndrome. Okay. Fine. Okay. Now this case.
So steroid dependent nephrotic syndrome, do we like try on steroid at a lower dose, like we try to
see what happens is steroid dependent nephrotic syndrome
get to a threshold and then continue, or like we'll immediately?
No. What happens is, now say this previous child, when on alternate day steroid, he was having a relapse. Alternate day steroid means 1.5 mg per kg, which is a high dose steroid. Yes. Okay. Say you have a 20 kg boy. Okay. How much is 1.5 mg per kg? It will come almost to 30 mg. 30 mg per day is his dependent dose of steroid. Now your low dose steroid is 0.5 mg per kg or 0.75 mg per kg. That is around 10 mg. So if you bring it down to that level, definitely he will relapse. You can't continue him on 30 mg daily steroids. No, it's a high dose steroid.
Correct. We have
so you don't give them that high dose steroid at all. So what you do is you put them in remission, give them full 2 mg per kg steroid for 2 weeks. Once they're in remission, you start them on cyclophosphamide or MMS.
Okay. Ma'am, in that case, should we alternate with steroids or alternate day steroids?
Yes, we give alternate day steroids. We give alternate day steroids and we slowly taper it off over a year.
Okay, ma'am. Okay. And this, how long we can continue, ma'am? MMF and cyclophosphamide?
Oral cyclophosphamide is given as a course of 8 to 12 weeks.
Okay, ma'am.
Okay, but MMF you can give for 1 or 2 years.
Okay, ma'am.
Levamisole also can be given for 1 or 2 years. MMF can be given for 1 or 2 years. Oral cyclophosphamide is given for 8 to 12 weeks.
Okay, ma'am.
Okay, fine.
Okay. Next scenario of this is of a 5-year-old boy diagnosed to have first episode of nephrotic syndrome in August 2020. Weight was 20 kg. He received 40 mg Visalon tablet daily for 1 month. He has no edema, but urine albumin on 3 consecutive mornings is 3+. Diagnosis and one additional investigations.
Yeah. So what is your diagnosis?
Yes, no edema. That means he's not still gone into relapse, ma'am.
He's not gone into remission.
Treated for more than 4 weeks. So initial
he has not gone into remission. Not remission. He has not gone into remission. Okay.
So initial resistance is
correct. So what I want to highlight here is, see, this is a 20 kg boy. He has received 40 mg Visalon. That means he's received 2 mg per kg per day of Visalon for 1 month, that is 4 weeks. After that, his edema is not there, but his urine albumin is still 3+. Remember, remission is not defined on the basis of whether the child has edema or not. Remission is defined on the basis of what happens to your urine albumin. It has to become nil or trace for 3 consecutive days. But here it is 3+. That means he has not responded to steroid at all. This is steroid resistant nephrotic syndrome. That is, when a child does not go into remission despite giving 2 mg per kg daily steroids for 4 weeks. That is when you call it SRNS. And now, since he has had this course in his first episode only, we will call it as initial steroid resistance. Yes, the other aspect is a late steroid resistance, meaning some child has today presented with nephrotic syndrome. He is sensitive. He has one episode per year for the next 2-3 years. He is responding. Subsequently, 1 episode, he will not respond. He is called a late steroid resistant nephrotic syndrome. Understood?
Yes, ma'am. Understood.
Okay, fine. Okay.
Then what additional investigations? We can go for biopsy.
Yeah, you can, Ala. You should do a biopsy in this child. Okay?
Yes.
So, can you tell me other indications for biopsy?
Renal biopsy, one is steroid resistance, ma'am. Then persistent hematuria can be there. All these atypical features, if we get increase in blood urea, creatinine.
Persistent hematuria, gross hematuria, AKI, sustained hypertension, less than 1 year of age, more than 15 years of age. Okay. I'm repeating the indications for renal biopsy in a child with nephrotic syndrome. Age of onset, less than 1 year. That is, all infantile and congenital nephrotic syndromes need to have a biopsy. Second would be after 15 years of age, because adolescent nephrotic syndromes are often secondary. They may be secondary to HIV, hepatitis B, SLE, and a lot of other things. So, less than 1 year, after 15 years. Then, sustained hypertension. Remember, hypertension is the obvious feature of nephritis and a rare feature of nephrotic. So, when there is sustained hypertension, that is a hypertension that is lasting for more than 2 to 4 weeks in a child with nephrotic syndrome, then biopsy is indicated. Gross hematuria. I told you already that gross hematuria is not a feature of nephrotic. So if a child with who looks like nephrotic is presenting to you with gross hematuria, do a biopsy. Then is persistent microscopic hematuria. I told you that around 20% of children with nephrotic syndrome may have some amount of microscopic hematuria. But if this persists, if it's lasting for more than 9 to 12 months, then again, go ahead and do a biopsy. A child with nephrotic syndrome with AKI that is not improving, okay? It is not pre-renal and it's not improving, then again do a biopsy. All children with steroid-resistant nephrotic syndrome. And what is the treatment for SRNS? Drug of choice?
Steroid-resistant nephrotic syndrome. Again, ma'am, levamisole only we...
No, this is steroid-resistant. No, what is the drug of choice? Calcineurin inhibitors. No.
Calcineurin inhibitors. Okay.
Yeah, what are calcineurin inhibitors? Yeah, cyclosporine and tacrolimus.
Tacrolimus can give.
So remember that even before starting CNIs, that is cyclosporine and tacrolimus, you should do a biopsy.
Renal biopsy.
Okay?
Yes, ma'am.
So,
why is it indicated, ma'am, before starting cyclosporine? Is it because it is steroid resistant we do, or is there any other reason for it?
One is of course that you're starting in a child with SRNS. The other thing is these drugs are also nephrotoxic. Okay. So you want to do a biopsy first and see that this is absolutely the disease itself. And subsequently, if the child has worsening AKI or something like that, you could attribute it to tacrolimus or cyclosporine. Okay. They are known nephrotoxic agents. That is why you should do a biopsy before starting tacrolimus and cyclosporine. What are the other side effects of tacrolimus and cyclosporine?
Hirsutism can be there, gum hypertrophy can be there.
These two are specific to which one?
Cyclosporine, yeah.
Correct, cyclosporine. So remember, in an adolescent who has steroid-resistant nephrotic syndrome, prefer tacrolimus over cyclosporine because these cosmetic side effects of hirsutism and gum hyperplasia will not be there. Okay?
Okay.
And tacrolimus again, what are the other side effects of tacrolimus?
Nephrotoxicity can be there.
Okay. Liver toxicity. Correct. All the ones that begin with H, no? So yes, side effects of tacrolimus are hyperglycemia, hypercholesterolemia, hyperkalemia, hypertension, renal failure, and liver toxicity. Cyclosporine will cause all of that plus hirsutism and gum hyperplasia. Okay. So very quickly, okay, next go. Yeah, so this is the child that you presented. Okay.
Yes,
this is your XYZ child that you presented. Okay. So what happened in him? His first episode was treated only for 2 months, correct?
Yes, ma'am.
So he was an improperly treated first episode of nephrotic syndrome. Now he has come with a first relapse. How would you treat him?
This will again treat him with 6 into 6 into 6 only.
Correct. So
as the first episode only we consider.
Correct. So that is the point I want to make here, that how well you treat the first episode will actually, predict how the future response of this child is going to be. If you have an adequately and appropriately treated first episode nephrotic syndrome, this child is known to have fewer relapses and his course of nephrotic syndrome is known to be good. But if the first episode of nephrotic syndrome is not treated adequately and appropriately, you know that this child is going to have a difficult course of nephrotic syndrome. Okay, this child has not got the benefit of 6+6 steroids ever. So although this is the first relapse, because of the first episode was improperly treated, here you will treat him with 6+6. Okay?
6+6. Yes.
Understood, no? Okay. So very quickly, I will tell you treatment very quickly. So first episode is 6+6. First, for relapses subsequently is 2 mg per kg till the child goes into remission, followed by that 1.5 mg per kg alternate day for 4 weeks.
4 weeks.
Then remember, frequently relapsing nephrotic syndrome, 2 arms. One is low dose steroid, the other one is levamisole. Steroid dependent.
Low dose steroids, then come to levamisole, or?
Yeah, that is what we do. Okay, the Indian guidelines say, see, a lot of Western guidelines don't have this low dose steroid at all. Okay, but for us, we know that steroid is the cheapest of all the immunosuppressants, and of course, it's the most effective also. So we tend to give low dose steroid over here for frequently relapsing nephrotic syndrome. Low dose steroid. If no response, levamisole. Which levamisole also you will give steroid. Okay.
Steroids, alternate day.
Alternate day steroid. Correct. Next is steroid dependent nephrotic syndrome. In steroid dependent nephrotic syndrome, oral cyclophosphamide and MMF.
Yes.
For steroid resistant nephrotic syndrome, CNI. Most important. Okay. That is tacrolimus or cyclosporin. The other alternative that we use here is IV cyclophosphamide. Okay. Remember, IV cyclophosphamide has a very high gonadal toxicity. Okay. So you should be very careful of using that. But again, because it's a very cheap drug, it's very easily available in our country, we give IV cyclophosphamide. CNIs are very expensive. Okay.
Yes.
So in steroid resistant nephrotic syndrome, CNIs are the drug of choice, but we can also use IV cyclophosphamide. Okay.
Okay.
Okay, fine. Done.
This initial resistance which we spoke about, in that case, do we continue steroids and try, or do we?
Okay. See, now here, what happens is
late responders can
correct.
be
so,
there.
Yeah, late responders can be there. Now, in steroid resistant nephrotic syndrome, there are 2 schools of thought. One thing they say that, see, this is steroid resistant. We have given for 4 weeks. They have not responded. It's very unlikely to respond. If we continue steroids, we're only going to keep adding on to toxicity. So what they will do, they will take off the steroid and give only cyclosporin and tacrolimus. There is another school of thought where they say that steroids actually will sensitize the child to tacrolimus and cyclosporin. That is, tacrolimus and cyclosporin may work better in the presence of steroids. In that case, for up to a year, they will give steroid. After that, they will take it off.
Okay.
Okay, this is very much physician based, and this is two different schools of thought. There are people who believe on either side and practice either thing. But by guidelines in steroid resistant nephrotic syndrome, as per Indian guidelines, you will start on cyclosporin tacrolimus and take off the steroid. Okay.
Ma'am, what is the role of rituximab, ma'am, then?
Yeah, so rituximab, what is rituximab?
Rituximab is again T cell. This thing.
What is it?
It's anti-CD20.
Correct. It's an anti-CD20 monoclonal antibody. Yeah. So this CD20 has been proven to be having an important role in the entire pathogenesis of nephrotic syndrome. So rituximab is preferably used for steroid-dependent nephrotic syndrome. Okay. They're usually given as 2 courses 1 month apart as an IV injection. Okay. But rituximab, these days, very often we are using rituximab, but the thing is they have some infusion related side effects which have to be taken care of. Otherwise, children do well with rituximab, and of course, it's a very expensive drug.
And we use it in case of steroid dependency.
Dependent, yeah. It is used in steroid dependent nephrotic syndrome.
Instead of cyclophosphamide or MMF, we can use this.
Not instead. What we do is we usually start with oral cyclophosphamide. If they don't respond, then we give MMF, give for about 1 to 2 years. In spite of MMF, you go to the highest dose of MMF, there is no response, then you go to rituximab. See, remember in nephrotic syndrome, everything is a stepwise thing. It is not this or this or this. Okay, so usually we start with one thing. If it doesn't work, then we go on to the next drug.
Okay. There are few doubts, ma'am. Ma'am, please explain overfill and underfill theory.
Okay, fine. Yeah. So overfill and underfill theory. Now, these are the 2 pathogenesis which have been proposed in nephrotic syndrome. In underfill theory, they say that the main cause of edema in nephrotic syndrome is hypoalbuminemia. Okay. When there is hypoalbuminemia, there is a reduction in the colloid oncotic pressure within the blood vessels. Okay. Because of that, there is an altered Starling forces. I hope you all are aware of Starling forces and how they work. There is an altered Starling forces because of which the fluid leaks into the third space. So in underfill theory, the concept begins with hypoalbuminemia. Okay. In overfill theory, what they say is, in a child with nephrotic syndrome, there is a primary intrarenal defect in sodium handling. Okay, here it is sodium. There is a problem with sodium handling. There is reduced filtration of sodium. So there is sodium retention and in turn water retention that causes edema. Okay, understood?
Yes, ma'am. Next doubt is, ma'am, premature atherosclerosis can happen in nephrotic child due to hyperlipidemia. Can it occur there?
It can happen in children with steroid-resistant nephrotic syndrome, and that is why there is a role for statins in children with SRNS. Okay.
Okay, ma'am. Ma'am, then what are post-immunization causes of nephrotic syndrome? They've asked.
Yeah, so that you will tell me. You have got the MD Pediatrics seat, no? Tell. What immunizations can give rise to? Yeah, what immunizations can predispose a child to nephrotic syndrome?
We read it as post-immunization. It can have, I don't know which one in specific. I don't remember.
Post-immunization causes.
Post-immunization, yeah. After nephrotics, for nephrotic syndrome, we'll give pneumococcal, varicella. This thing we give to protect the child.
Think that is what they are. Yeah, to protect the child, you will give pneumococcal, varicella, all of that. But I think the question that they're asking
what
is,
are the post-immunization? What are the immunization
causes of nephrotic syndrome? I don't know. I think it means after which immunization will you get
mostly that meaning that.
That you tell me. You have only recently given entrance, no? Pediatrics in BMC, that too.
Forgot, ma'am.
Forgot. Okay. Influenza vaccines, rabies vaccines. Okay. These are the ones that can cause that are proposed to be causative agents for nephrotic syndrome. Okay. However, we don't really give it that much importance. But you should remember, measles is one thing. Immunization is one thing that causes prolonged remission, infection or immunization. Okay.
Okay.
Okay. So you should know what are the vaccines that should be